As we know, those of us involved in this work, medical interventions can be especially challenging in developing countries. And there are challenges that need to be addressed, and sometimes they're addressed in ways that are different than they might be addressed in our home countries. And so that's a little bit about what this panel is going to talk about. Mr. Sam Bundren, who's seated next to me, is HCW's Monitoring and Evaluations Project Lead. He graduated from the University of Virginia in May with a BA in psychology on a pre-med track. He's traveled to Sierra Leone for HCW twice, once as a short-term missionary with me, and then most recently has been serving as a long-term missionary intern in Sierra Leone. He's just back after 3 months-ish there. We have him back here for a few months, and then he's going back. He also served HCW as an intern during the summer last year, helping set up the data analysis work that we do with the hospital that we support in Bo Sierra Leone called Mercy Hospital. He's interested in the medical field and its intersection with data analysis, which makes me very excited, woohoo, which is a topic he focused on at school. And he's going to moderate this panel and introduce the other panelists now. So here you go.
Thank you, Laura. I think what I'll actually do is have everyone go around and introduce themselves, and maybe we can talk about the work that you've done within the medical field and its intersection with mission work. Carol, if you want to start us off, that would be great.
Well, good afternoon, everyone. I'm so sorry that I'm not there. How do I start? So I'm Carol Macintosh, OBGYN training, and have been an OBGYN for that many years. My first start for medical missions started about 2 years after I finished residency. I was in private practice and started doing medical missions in Grenada, Carriacou, Pt. Martinique, in the Eastern Caribbean. And that started off primarily with lay people, just everyone who wanted to come down. And that continued up until about 2003, when we realized that the missions we were doing were probably more triaging as opposed to providing more of an impact. And so myself and two other people, we got together and we built an ambulatory surgical center in Carriacou. I must say Grenada is about 100,000 people population total, and it's a tri-island state, with the main island having 90,000, smaller Carriacou, where we built the health center, having 5,000 people, and a smaller island of 500. I moved down at that point, put my practice, actually sold my practice, which was in Manhattan, and moved there for about 5 years. And then in 2011, moved back up and actually migrated over into Maryland and Virginia and started working there. And from there, was introduced to Helping Children Worldwide, which is an interesting story in and of itself, and started working, doing missions with Helping Children Worldwide to Sierra Leone. So I continue with that, as well as working with Globathon, which is an organization, not for profit, to reduce women's cancer or eliminate women's cancer worldwide. And we are based in about 80 countries. So my enjoyment is women's care. My enjoyment is traveling. Right now, I'm now in Grenada. I returned here October 2018 to take on the post of Director of Hospital Services with the Ministry of Healthcare in Grenada.
Perfect, thank you. Do you want to take us next? Thank you.
So good afternoon, everyone. Can you hear me okay? So I'm Cynthia Horner. Hi, Carol. And Carol and I haven't seen each other in probably a couple of years, so it's really wonderful to see her face. But I am a medical physician by profession. Family practice is my area of specialty. I've been in practice for roughly 25 years now, which feels sort of startling. I don't know where the time's gone, but my passion and the bulk of my practice here in the United States is women's and children's health, and particularly focusing on prevention. I got involved in initially in relief work through a partnership of churches, starting with Flores, that gradually helped give rise to Helping Children Worldwide. All of my medical work, again, starting as relief, later kind of evolving more into a development perspective, has been in Sierra Leone. So I have traveled to Sierra Leone more times than I can count. It's probably less than 20, but it's somewhere more than 12. So not as many as a number of you in this room that and on the phone or on the video that can talk about years living in other countries. But I bring to this discussion a lot of lessons learned on what not to do, and hopefully some perspective on what seems to work over a couple of decades of trying to make a difference in improving the health and lives of communities.
Thank you. I'm the last minute fill-in, so I was back there, and Sam knew me, I guess, and so he just. But my name is Gary Gillison. I'm a physician. I'm in Charleston, South Carolina, at the Medical University of South Carolina. I'm a rheumatologist that specializes in lupus, which there apparently supposedly is none in West Africa, which was one of my major interests into trying to figure that out. But obviously that's not the main reason I go there. But I've done mission trips like you were mentioning that I don't think were helpful to Haiti and Dominican Republic and others. And then I've been to Sierra Leone 5 times, all to Bo, 3 times with the West Africa Fistula Foundation, and then twice with HCW, and have really enjoyed the interactions and have ideas, but I'm interested in participating in this. One of our NABs was here. He came and visited us at MUSC as part of a global health thing, and he was overwhelmed with the fact that we have 800 physicians at MUSC, and there are 300 physicians in all of Sierra Leone. And so he was just kind of taken aback at the differences and magnitudes and everything that are between the 2 countries.
That's a heavy microphone.
Yeah.
Good afternoon, and thank you very much for this opportunity. I promised I'd only take 3 hours. My name's Cathy Griffith, and I am originally from Zimbabwe, so I'm another African attending here. As a little girl of 7 or 8, I was absolutely convinced that God, whoever he was, had called me to serve him in a distant land when I got to be an adult. And that sense, that dream stayed with me. And when I committed my life to Christ at age 16, I began to make career choices in line with that, and so became a nurse, became a midwife, became a community health nurse, and much later did some studies in behavior change to understand why people made the health choices that they did. To make a very long story short, I have worked in Zimbabwe and South Africa, and then spent almost 15 years in Afghanistan as, they called us in the West missionaries, but there I was a development worker working with women in women's health, in community health, trying to find the best ways under the Mujahideen, under the Taliban, and then the post-Taliban government, how women could find the best care and how women could get knowledge about themselves for their own health and their children's health. And of course, sorry men, also so that men would understand more about women's health. And then to leave out a big gap, I'm now working, I was with the General Board when I was in Afghanistan, because my husband is an American and he was with the board, so I'm adopted. I now work for the board in Atlanta. We have a global health unit. How many people here know the Imagine No Malaria campaign that Nyama and Shannon? This was the denomination's focus for 8 years, was all about malaria in sub-Saharan Africa, with the fundraising mostly here and the implementation in sub-Saharan Africa. That's now completed, and we have a new initiative called the Abundant Health Initiative that embraces women and children under 5, so it still keeps the malaria component, but is all about engagement with the community. It's all about strengthening the United Methodist hospitals so that we can get women with the healthiest possible pregnancy, the best possible delivery, postnatal care, and care for the children until they're 5 years old. That's my work, the maternal, newborn, and child health aspect of it. And it's a real privilege. So we don't sleep at night, we just buzz.
You can hold on to it for now. So first, I think we can talk. Carol, can you hear me?
Yes, I can hear you
Okay.
very easily. Yes.
So first, I think we can kind of focus on the big picture of global health and healthcare, and then we can get into specific instances within all of your different fields. So my first question is, what do you think the most difficult challenges at this point in time are in administering healthcare in developing countries? And Carol, we can start with you. Again.
Okay. Not a problem. I would say access, or the lack of access, and the lack of resources. And that may sound just general because we are talking and it will continuously come up. But the lack of access, not so much just really within the person being able to reach to the physician or to the healthcare provider, but the healthcare provider being able to get whatever resources they have to the people that most need it. That's in the sense of that lack of access and the lack of resources, which can start from simply unsafe water supplies to enough instruments to be able to provide some type of surgical care, as well as the specialists that are needed for that. So the lack of resources, both human, medical equipment, as well as the other resources that are necessary. And what's the cause of this? Because of the fact of the high rate of poverty, because of the fact of the unsafe water, because of the fact of hunger, because of the educational system, because of the economic system within the different countries.
Thank you.
That's it.
Cynthia, you can.
Yeah, so Carol, I not surprisingly share your perspective and your opinions. I think one of the biggest challenges that we face globally as a global population, as people, is particularly in areas that are impoverished or under-resourced from a number of different, for however you want to define that. The complexity of disease is heightened because of a lack of fundamental healthcare parameters. So let me explain what I'm talking about. Ability to actually drink clean water. That is something that we take for granted and is such a simple, basic infrastructure, but it's not simple. And anybody who's actually done any work internationally, when you look at trying to fight maternal mortality, lower maternal mortality rates and fight some of the issues around that, well, one of the first things you have to do is you have to think about, okay, nutrition. And when you start getting into nutrition, suddenly you unearth hygiene issues and toileting issues. And so it's really difficult to go in and just solve a single problem without understanding the wraparound, whether it's services or baseline health of a community that needs to be supported as well. So I think we probably all in this room that have done this kind of work have realized that we might go in with an idea of a clinic, or we might go in with an idea of a malaria program, and suddenly you realize that you've got a malaria nutrition, hygiene, toileting, and water program. And how do you do that effectively and appropriately? And there are answers, and we've been hearing about some of those, but to make a very complex answer succinct, it's fundamental infrastructure for basic access to just basic health, sanitation, nutrition, water.
Yeah, I don't have a whole lot that, obviously those are the big ticket items. I think as they solve the children and the mortality rate, then someone's going to have to take care of the adults, and that's where I come in. And so some of the things that was mentioned in the last thing is about preventative medicine, which is a big ticket item here, and there are a number of preventative things that are not easy to implement, but I think there are things that can be done even now and then that could be helpful. But you know, like I said, access, people getting to the doctor, being able to see the doctor, being able to pay the doctor, those are all things that just are very difficult to overcome.
I also have 3, and it's the big A again, access. Whether it's being carried in labor in a hammock, or making a contract with a taxi union to be able to take women from a village to the health facility, or arriving at the health facility and the health staff have not had access to medicines. So you've gone there for nothing. So access is a big one. But I have 2 others that we haven't mentioned yet that are really important to me. One is respectful care. The United Methodist health facilities, most of them in sub-Saharan Africa, are in private-public partnerships. And very often, the staff are government staff, or they're not church staff, or they're not Christian staff, let me say. And all of us Christians, maybe I should just be doing this, we're not perfect. And people don't always want to be stationed beyond the end of the road, and are impatient with women who have not been to school or have not taken the most obvious care of themselves because they haven't been able to. And I have seen the most disrespectful care that if it were given to me, I would never, ever, ever go back again. And so I think that's a major thing in one of the major challenges in health. And the third one is the need for effective supervision. I'm working with maternal, newborn, and child health program officers who supervise at the health facilities that we're working with. And it's really important for them to be effective so that they can have on-the-job training, on-the-job understanding, on-the-job context, on-the-job respect for people who haven't slept all night or who have walked all day. And those 3 together, I think, are quite transformative, although these other needs we've spoken about are obviously huge.
And coming back to you, actually, Kathleen, can you speak about some of the attempted solutions that have been implemented and their successes and failures that you've seen throughout your career?
To the lack of access?
Yeah.
Everything? Okay. In Nigeria, our sister Joyce, whom some of my friends here know, she gets together the women in the target communities and has a really effective time speaking to women. But she's also begun to get the men together. The men haven't let their women go to the health facility because 1, they don't want to pay for it. 2, they're also in a Muslim community and they don't want their women to leave home. 3, their mothers stop them from allowing their wives to go. And so Joyce has been talking to the men who've realized now the medicines are free. And so they're gung-ho, plus some of the men drive taxis and are part of a taxi union, so they've signed a contract. So they get paid by the clinic for responding to an obstetric emergency, and so they're part of it. They are part of the ownership of healthy women in their community. So another story about access is our project in the far western development region in Nepal. I could not believe it when they asked for a few $1,000 for an emergency transport fund. What would you want all this money for when you have to walk everywhere in Nepal? Well, in Nepal, you sometimes have to walk 6 days to get to your nearest birthing center, but there are roads. And what the organization wanted to do was start an emergency fund in negotiating with the government, the municipality, and the community. And actually, it's turned out that they thought it was such a good idea that they've all contributed equal parts. And now it's equally funded, and we had a story from a lady who said, I attended my prenatal clinics and everything was fine. But as you know, things aren't always fine, even if you go to prenatal clinics. And I had an emergency, and the nurse at the birthing center said, I can't help you, but you can take a loan. So she gave her a loan from the emergency fund, interest-free. They got to the referral center. She had her baby. She got home in 2 days, and they paid the $39 back inside 3 months. This saved her life, and it saved the baby's life. So 2 stories, 2 examples.
Do you have any examples, Cynthia, on kind of implementations or successes you've seen in regards to healthcare in general?
Definitely. Where should we start? How long do we have tonight? No.
Right, exactly.
So I think Cathy brought up a couple of really key core concepts, one of which is local buy-in. And frankly, not just buy-in, but the origin of the solutions. If they come from the local community, they tend to be far more sustainable, which is, again, a really key value. And we heard in the session just preceding this about examples where, or one example, where the solutions just were not sustainable. So we've been doing this long enough that I can give you some examples of non-sustainable solutions and best intentions. But to get back to the question, when getting local buy-in, when Carol and I took a trip probably now about 8 years ago to Mercy Hospital in Beau, Sierra Leone, at the request of the local medical community to provide cervical cancer screening, which had never been done at all in that area, and was just starting in the capital city of Freetown. So Carol's goal was to bring the equipment, train the local staff, and do, frankly, on-the-job training with the equipment to do cervical cancer screening and to set up a program. The first, Carol, was it 2 to 3 days where we actually spent meeting with various country leaders or local leaders? And,
yes, exactly. The mayor of the different villages, exactly, to start to just explain to people. And again, we brought down the uterus, explaining not just about pap smears, because it's not, when we talk about cervical cancer screening, you can't do paps and out. Just briefly saying, we started doing the pap smears, but then that means taking it back to the US to get the report to come back. So the next step is the VIA, visual inspection with acetic acid or your table vinegar. You just need a light, a speculum, and it doesn't have to be a regular table, but just the ability to be able to examine women. So it's one stop. So be able to examine and be able to provide treatment. So I'm going to bring it back in because there's several points that come in with that, but we sat with the different leaders to be able to come in.
So getting local buy-in, and the first question that comes to mind is, my goodness, if you're going to do cervical cancer screening, are you really opening up a Pandora's box in a country that can't even screen for it? What do you do with a positive result? So thinking through, and the answer is we did think that through with our local partners, and there are some actually very that gets to the second stage of what she brought, which was some local treatment capability and teaching people how to detect early and to treat early. So you're taking the cues from your local community and providing that sustainable ongoing training so that you're not just going in, doing 2 weeks worth of care and then jumping out. I'll leave it at that. I've got a few other stories, but I'll save those for the next question.
Thank
Just
you.
to add on to that though, it's more in the sense, like you said, sustainability, but also empowerment. And I think this goes back to Cathy is talking about the respect that you would have, where a person is now able to say, despite all, I'm able to be empowered in taking care of my health. So it is about, yes, we come in, that's providing the access and awareness, but being able for sustainability to be able to provide to the healthcare providers there, you continue with this because we're not coming in all the time. We are stopped. We were stopped by Ebola. We didn't come back in for another 3 years. But that doesn't stop cervical cancer spread. That doesn't stop the screening. It has to continue. And as we talk about, Cynthia pointed out, we're talking about we're going to hit the patients who had the precancerous lesions and start to treat that and hopefully stop the furthest trend towards cervical cancer. You may say, but then when you pick up cervical cancer, what can you do? It is true. We had women that also came in with stage 4 cervical cancer who were bleeding out as they're sitting there, who had walked 4 miles to come in and say, what can we do? You can actually, and I don't want to be graphic, you can smell the cancer. You can smell what is going on. What can you do? We don't have radiation. We don't have chemo. What can you do? For this woman, what we can do, we did send her to the general hospital. The most we can do, hopefully transfusion, pain relief, pain management, helping to say if we cannot treat, we can't stop the cancer, but let us take care of all that comes with that. That's what you can do. That's a start. And so it is saying, well, if you bring this in and you can't provide the next service, what's the point? No, you bring this in and it helps because now you provide another service, hospice type of care at home. Because we were able to partner with a nurse who was saying, I can bring pain medications and I can go visit with the women. So then again, so it's now a woman who has cervical cancer, but she would have her family. And I remember what a family saying, well, what more can we do? And it said, we cannot do more, but help her to be able to manage the pain. We can help her to be able to manage, to be able to go through. And when we talk about my faith is so strong, it's so much a part of it, is that it's not just about the sake of giving medicine, but also about the sake of saying, if we have to extend, we have to say that this person is going to move on. She is going to die. At least we help with that whole process of being able to accept it. And if your faith is strong, it's like saying, okay, well then how do I manage through this? So that was one part of it, as well as being able to teach to get the precancerous lesion and hopefully stop. But those who have the cancer, being able to help them to manage it with what resources you do have. And then still looking for further resources because you're gonna keep building up on that. But the empowerment for the person that's there, the empowerment for them to be able to say, we are doing this, we are doing this. I hear when you're saying that the husband is being brought in, there's a woman that needed a lead. For her, she was saying no, as we translated back and forth, no, I can't. But it was basically saying, no, I can't, I need to speak to my partner. I'm gonna be very blunt. If we were sitting in the United States, people would start to say, well, what are you talking about? Take care of yourself. You don't need to have your husband say this. But you have to stop. This is what's going on. This is economically. She has to talk to those who are there with her. And her partner came on his motorcycle, came in. When we explained what was necessary, he says, yes. So he understood not only what was necessary, also understood that no, she could not be sexually active, also understood why that was the case, and understand that she needed to come back in for follow-up. So he also was empowered and part of that. And within going through this, now saying, I can assist my wife when we go back home, I will help to take care of her. So it's recognizing where we're going in, how do we help? And recognizing help may not be in the way that we believe that it should be. Oh, help is gonna be, I'm gonna get her radiation, get her chemo. Help is, I'm gonna help her to manage what is going on now. That too is just as important.
And that last point you made makes me think a lot about a question that I thought of earlier, which is how can indigenous or traditional health practices and kind of our Western ideas of health practices or medicine coexist? And not that they're always conflicting ideas, but in the instances when maybe there's two different approaches, what do all of you on the panel think is kind of the best way to go around making those agreements? And Gary, if you have any thoughts, we can start with you and then go down.
I don't have any real thoughts. I mean, it's a difficult situation, as you know, to deal with, and the alternatives are fine as long as you've pursued the medical type things. But a lot of the people have no access, which was brought up, so that is the only medical care they have is in the village with that person. So it's a difficult situation.
Yeah.
So I'd love to tell a story that illustrates this. And it was from probably about 10 years ago. One of the nurses at Mercy Hospital developed a one-sided paralysis that was waxing and waning. And it was after a fever, but her symptoms persisted. And she was of the belief that she had been cursed. And she was brought to the hospital. The hospital treatments were not effective. And so after 2 weeks of hospitalization, her family took her out of the hospital and took her into the bush, which essentially meant that she went to go see a traditional healer. And after 3 or 4 different episodes of seeing the traditional healer, in this particular situation, there really wasn't a whole lot of improvement, and so they brought her back to the hospital. Now, the hospital that I refer to is staffed by a Sierra Leonean physician, and at that time was also staffed by a Sierra Leonean physician that was trained in Sierra Leone, and he was a Sierra Leonean native. About the time that she had been brought back to the hospital, we had a medical team that came over, and so this is actually how I know the story, as I was there. And the physician who was the medical director of the hospital said he wasn't sure what kinds of treatments were being done, but that they hadn't worked. And I asked him if he knew the traditional healer. Had he ever actually talked to this person? And there were a number in the community, but this particular one he didn't know. And long story short, we agreed to have somebody reach out to the healer and ask if we could meet, with the idea that we all collectively cared about this patient, and recognizing that much of what they do is very private and secret and proprietary, honestly. And we weren't looking to take any of, in this case, his treatments, but perhaps we could come up with a collaborative way to help her. And the family thought this was something that they were very supportive of. And it was a remarkable experience to go and meet with a traditional healer, to understand, just to watch a Western physician, not me, the doctor of mercy. I was just the observer. And to watch the two of them talk, have mutual respect, and come up with a sort of cobbled together, honestly, plan of care. In retrospect, I think this woman actually had encephalitis, and she had probably a viral encephalitis, but that's our understanding of this. So I think, to answer the question using this illustration, we use terms based on our Western medical knowledge that has a whole structure behind it of germ theory and a whole host of other things. Traditional healers bring a different kind of, or indigenous cultures bring a different kind of understanding of disease process to begin with. And in order to actually have an impact on outcomes, we have to start with what somebody's understanding is. Another example that I have, and I'm just going to be real brief with this, the first time I went, I was stunned by how many patients would come in the door, and you'd ask them through a translator sometimes, what can I do for you? And you get every symptom that they've had in the last week, including the main reason that they came, which might have been their upper respiratory infection. But then they also had a rash, and 6 months ago they stubbed their toe, and 2 years ago they did this. And I don't bring that up to mock it, but I bring it up because the understanding of what goes together, it really highlighted for me how much of my medical care training is based on decision trees and an organ system, and how that is not the case in many other cultures. And so if I'm going to provide care, I have to understand how that toe relates to their cold, and not just dismiss their toe and say, well, there's nothing to do with this, because they'll come back for the toe. And so open mind is the one-word version of that answer.
Yeah.
Mm-hmm. And just to add to that, it is very true that you have to, and Helping Children tells us this, you leave some of your stuff behind and listen. I think my biggest one is when we do the outreach, and I'm going out and doing ultrasounds for pregnant women and trying to learn Mendi. And women are watching, They're watching through the mirrors as I'm doing the ultrasound. I'm saying, this is what's going on, and laughing with my translation of the head and the heart. What I thought, because I'm sitting there coming in and talking to women and saying, coming for prenatal care, what was great is that the different villages came in with their doulas, with their healthcare person who works with them and sees them regularly when they're pregnant. They had taken with the government that said that they're not necessary to do the deliveries, but they are the first persons there. And we have to recognize and respect that this person is the first responder. So I brought him in as well and trained and said, well, look, you may not have the ultrasound, but if you're feeling for a breach, you can see where the head is, now feel. And we work together in that. And then explaining to women, you need to come in and be seen, not necessarily be seen by the nurse and the doctor, which is great, but if necessary to see the doulas. So now we're all working together. And what was most fascinating, after I said that, I said, well, how do we get this across? The doula and the nurse put together within 5 minutes a song around prenatal care, coming in, making sure your baby can move, coming in because you want to make sure that your baby's going to do well, coming in because you want to know whether you deliver at home or do you need to go to the hospital. All of this in a song. All of this where all the women were singing. And we don't do this in the States as well. We're trying to get our women to understand this is what you need to do for prenatal care. We've already reached out to women where we're saying, oh, they may or may not understand. They understood very clearly about prenatal care, the need, and who do you reach out to. That struck me as, that provided more than my bringing prenatal vitamins. That provided more because it's empowering the women within their village and for them to understand and saying, I need to get in to be seen and I need to respect, and we show respect for who you have here for care. This is the doula. That person is just as helpful as myself. And the doula also came up to the hospital to see where the person would be going. They made their way out there. So they can put in the village, this is where you're going to do. I think that's one where we start to understand that we are all integrated together, that when we're looking to provide healthcare, but we can't say we're bringing this in without recognizing what's there. We have to be able to be respectful and help to empower, help to make people aware, just as we become aware of what is the best of healthcare, because our faith tells us that we're not the ultimate healers. So we have the tools, but the different types of tools are going to be working together.
What a wonderful answer. Thank you. I have one small thing to add. I think the question is absolutely outstanding. Thank you. You see, I don't know how you think, but I'm a 1, 2, 3, 4, 5 woman. You know, I do it 1, 2, 3, and that's followed by 4, and that's because that, and everything is so reasonable. Well, at least I think it is. But I've discovered working in Asia and in Africa that life is so much more integrated. Illness is not just about my body. It's a body, mind, spirit, and community. It's also my history. It's also where I come from. Everything is involved in this illness. And so I need to pray this much more, but I often pray that God would give me very big ears and a very small mouth, just so that I can take the time to listen and understand much more than I do. In some cultures, women are forbidden from giving the colostrum, the first milk, to their newborn because it's dirty and they'll get sick. Well, that's the worst possible information I could give any mother. But I need to find the source where did that come from? In some cultures, women who are having a hemorrhage in their pregnancy are beaten. And why are they beaten? Because they have an evil spirit and it's being exorcised. So I need to understand that so that I can have a response. So this is the simplistic part. If the custom, the myth, the medicine, the background is harmless, I'm just going to include it in the care that I give. If it's something that's going to promote, let's use that instead, and we all own that good intervention. But if it's harmful, hopefully by listening, I will have the trust and the bonding to have my patient respond and say, okay, I understand, I won't do it that way.
And to wrap up, just as a conclusion, and this is so cruel of me to give you this question as the conclusion, but can you talk about, based on your experiences, where you see the global health field moving or changing in the next 5 years to decade? What recent advances you've seen and how you think that will shape the field as a whole? Anyone who wants to tackle it first, go ahead.
Well, if you happen to be bored during this session and we're reading bios and saw my bio, it's not going to surprise you that I'm going to talk about telehealth, because that's what I do professionally. And I think, when I first went to Sierra Leone back, it was like 2002, I remember making a phone call back to the States, and in order to do so from the city of Bo, we had to go to one of 3 telephone booths at the phone service company. 2 of the booths were out of service. We had to actually get coins and put them in the phone, and when that particular call didn't go through, we were told to go to Freetown. By the time we got up to Freetown, at the end of the week, we didn't rush up to Freetown, but they actually brought us into their office building, and we made a phone call from their desk phone, which was sort of light years in advance. So fast forward 4 years later, everybody had cell phones, leapfrog technology. So I honestly think that there is, and Sam, you've probably seen some of this in your M&E, and those of you that do M&E have seen this, the use of cell phones to gather data and transmit data real time. But from my perspective, the use of technology is going to revolutionize not only healthcare in the developing world, but healthcare here in the United States and in Europe.
What was the question again?
Where you see the field changing in the next 5 years?
5 years is a short time frame.
10
I
years,
think
20 years.
10 years, 20 years. I mean, I think the development of, further vaccines for some things, if there's ever a malaria vaccine or whatever, then that would be a game changer, HIV vaccine. So hopefully that will be a considerable game changer along those lines. And then telehealth, I think, is obviously another big area where it'll be change things, because even in the most rural areas, you could get expertise.
Thank you. This question was in our preparation, and I wrote a column for the worst scenario and the best scenario. So I'm thinking 2 things. One, I'm wanting us to be really nimble as we look ahead. I think I'm going to have to think about things in a very different way. One, because of the social determinants of health. There is war, there is global warming, which makes me think about flooding and food insecurity, people migrating, people being on the road and out of their context, unable to provide for themselves, war, as in rape as a weapon of war, as children never getting to school, as in violence. And I think this has a tremendous impact on health, as well as Ebola. And we're doing a little bit better with HIV right now, but there's still malaria, there's Ebola, and there may be other pandemics out there. And so I'm really wanting to be reading and getting help on being nimble. How can we respond quickly and with understanding to get to the most people quickly, but also to get to the ones and twos and to the women and children.
I think as we look at that, before I even go into it, I'm truly humbled in the sense of being on this panel. But this, helping children worldwide, the various organizations that are represented here, that's part of what's going to help the change. Because this is part of the change and how it impacts. 2 parts. One is with helping children worldwide. We stop and believe it. We hear Dr. Cynthia talk about how we came in and helped to build a hospital. We started the orphanage. That started, so we brought in access. It continued to train those who are there. to continue sustainability. And now you have Sierra Leone taking control and continuing with this. That is one where you have to empower the group that you are working with, giving them the ability to be able to be sustainable. How do you do that? Yes, with telemedicine, but also training your own who will be willing to come back to home and providing the care. That's one major thing. The other one is to recognize that health and economic go hand in hand, are very much intertwined. So when you look at the government leaders and we can't talk about global health without looking at what is going on in the world today, without looking at what's going on with the developed countries, without looking at what the leaders are doing, because that's impacting directly on the developing countries. And right now, the leaders are stay home. I don't have to talk about what's going on in the United States and the leader and what it is that he's trying to push. But I talk about in the various other developed countries where they're saying, I can't do for everyone because I have to take care of home. We have so many problems of our own. We have Brexit, we have this, we have that. We have to do here. So they're now shifting their care back into home and recognizing that the countries that are in need start to look to say the group. I look at it from like the Caribbean as well as looking in the African continent. Within the Caribbean, the smaller countries here, they're talking about you can't. A country of 100,000 or 200 or 2,000 or 300,000 cannot sustain for help with their people. But if you take 12 of them together and put them together and say, well, one, you will be the center of excellence, or you will provide this care, and we will see how we can pool our resources so our people can get back and forth. That's one of the answers. Now for the African continent, it is different, but it is the whole thing of how do we pool the resources there. It is a problem, economy, education, etc. But with telemedicine, how can we help to train up and recognize to come outside of the box? You don't have to be a physician. You don't have to be a nurse. You can be the person that's the technician that's starting to say, I'm providing this care and expanding it. And last is Dr. Goswami Parham, who's talked about cervical cancer. He said it very clearly. He says we have to look at the social determinants because those are major. Poverty creates cervical cancer, which creates poverty. And this cycle is there and it's killing. How do we intervene? So you can't just intervene and say, we're going to try and look at cervical cancer and give the vaccines and the screening. But we have to look at the poverty and see how that impacts and how do you impact there. And how can we help? Training within the education, training people there, providing the care, because at some point we may not be coming in, but it continues with sustainability. And when you provide donations, it's not donations saying the largest of things, but the simplest of things. How do you, as Cynthia Cook did, how do you start with to talk about providing better water care? That we started off talking about unsafe water, poor sanitation, hygiene. Those have major impacts in healthcare. And sometimes it's the simplest of things, taking care of that can impact widely. So as everybody knows, I believe God to every extent that what is going to happen in the 5-10 years, as we continue with Happy Health and Chill Worldwide, as we have like the global health missions, as we have the people come together and recognize what I do, even if it's one thing, impacts. And gradually grow on that and tell people and educate and integrate and allow for those who are saying the traditional healthcare workers, yes, you're in line with me because we're all working towards the same goal. That will help to impact and hopefully help to improve, because it can only improve. It has to. We don't have the option. It has to improve.
Well, thank you, Carol, Cynthia, Gary, and Kathleen. This has been great. It was lovely talking to all of you. Thank you so much.
Thank you. I just want to say I would like to get Fadia's cookbook. I am just saying.
We'll hold a copy for you, Carol.
Yes, thank you.